Right, good afternoon, everyone. Welcome to this joint Leicestershire and Rutland Health Scrutiny Committee on Wednesday, the 27th of March 2024. It's 2 p.m. We're here in the Sparking Hoe Committee room at Leicestershire County Hall, so welcome. Just a little bit of housekeeping on the buttons for those that know the system. You'll know that the cameras at the four corners of the room respond to the red light being on your microphone. So when you do want to speak, wait for the sort of hand up or whatever. Push the button, red light will come on, the cameras will zoom into you, and you're beaming out to the millions of people watching on YouTube today. Otherwise, when you have finished speaking, if you can please turn it off, otherwise it confuses the cameras and the next person won't actually be seen. But hopefully it will all work smoothly. If for some reason you have problems with the particular microphone unit, there are a couple that I think are slightly more temperamental, hopefully not any that are actually out today. By all means, don't give up. We'll get it resolved through you, and so hopefully it should be fine. So I mentioned YouTube, I mentioned housekeeping, and obviously we've got the agenda here today. We have had a substitution from the agenda as published, which is that Councillor Wesley has been, I think, permanently substituted by Councillor Moderati. Now, you're going to help me. Where are you?
He's not here.
It's not here. Right. Okay. Well, in which case, I was going to say, as everyone at County Hall knows, I absolutely, completely destroy all names. So Sanjay, when he eventually comes, hopefully will make sure that I'm correctly pronouncing your surname. What I will do today, if you don't mind, is actually use everyone's first names. That helps, I think, because there is a mixture of councillors and misters and misses and doctors, etc. in the room. I'm going to be super casual today and just use everyone's first name, if that's okay. If anyone objects, by all means shout, but hopefully it's a bit more friendly, and also it helps me with my limited capabilities for getting titles right. So thank you to all of you. Welcome to also to Janet and Harsha from Health Watch Rutland, and also Health Watch covering Leicester and Leicestershire. Otherwise, to the rest of you, welcome, and we'll go on to item 1 in that case, which is minutes of the previous meeting. These were the minutes of the meeting held on December 2023. Can I take it that everyone's happy with those minutes? Those are excellent.
Sorry, that's my mistake. I'll make that correction.
Okay, I did mention that to you in a couple of hours ago, so he was aware of it, and it's mod.gov, which is the system that we use, and I think probably County do as well. Well, certainly City and probably Rutland do as well for publishing stuff. It's great system, but as Ewan will tell me, the bit that the officers have to use is an absolute nightmare.
That's my excuse anyway.
It's a good excuse. It's a good excuse. Okay, so that is item 1. Item 2, question time. Haven't received any questions from the public. So on to item 3, questions from members. Haven't received any questions from members. Item 4, urgent items. Haven't received a notification of any urgent items, so we won't take any of those. Item 5, declarations of interest. Bessie. You.
Son and daughter work in the NHS. Yeah.
Are there any other declarations that anyone needs to make? Brenda.
Thank you. Chair, my daughter works for the NHS.
Thank you very much. Oh, Ross, you sort of work for the NHS, don't you?
Just the normal one as a dentist living NHS services.
Any others? I think we all attend the NHS as well, so that probably is a wide declaration. Okay, well, look, thank you very much for that. Item 6, presentations of petitions. We haven't received any petitions. Item 7, we have John, hopefully, is with us. So, Rashna, fantastic. You're not on my agenda, Rashna, so it's dreadful, isn't it? You can't get the staff these days. Well, there you go. Well, look, it's lovely to see both of you. Thank you very much for coming along. So obviously, this is the University Hospitals Leicester Operational Improvements 2023. You've sent through the paper. We've had a chance to read through it, and thank you very much for that. Look, there's a huge amount in the paper. I know you'll want to answer lots and lots of questions that I know will be around the room about how things are going. As usual, we'll take the paper as read, but if you want the next couple of minutes just to highlight any particular things in the paper that you either need updating since the paper's been published, or that you wish to draw our attention to before we actually start on points and questions, over to you two.
Thank you. Thank you again for the introduction. I'm John Melbourne. I'm the Chief Operating Officer at University Hospitals of Leicester. Thank you for having me today. I'm always delighted when I come at the declarations of interest that there's family members that work in the NHS. I want to see more of that every time I come, please. We do need colleagues to join the NHS. Very grateful for it. So what we've provided today is a summary through the calendar year 2023 of our improvements in operational performance, and we've split it across cancer, broader planned care, diagnostics, and urgent and emergency care. Hopefully it is reasonably clear, and the charts show where we've improved and where we have challenges still. Just a couple of things that I would like to pull out. So firstly is we started 2023 in what is the highest level of support in urgent emergency care, cancer, and planned care, which is in tier 1, as they call it. We ended the year being in tier 2 for both planned and cancer, so we're out of tier 1 and removed from tier 1 and tier 2 for urgent and emergency care, which I think is an overall shout. So it shows the trust that the national team have in us, that we're moving in the right direction, and the progress we are making to that end. We include in the summary slide lots of examples of how we've achieved progress across the year. I will move to slide 3, which gives you some of the headlines. So cancer, we've had an over 60% reduction in those patients waiting over 62 days for their care, from well over 900 to, as of today, fewer than 300. It is not, and you'll hear me say this a lot through this, we don't accept where we are, and we are proud of the progress we've made. And those two things, I think, can be true at the same time. Electives, we've reduced our waiting list. Our longest waiters, so those over a year and over 65 weeks, we saw the biggest reduction of any system, any ICS in the country in 2023, and the second biggest in terms of total waiting list. Again, we don't accept where we are. We still have too many people on our waiting list, with just over 100,000 people, but we have made significant progress and nationally leading progress in reducing our waiting list. Similarly with diagnostics, a 43% reduction in the overall waiting list, and the longest waiters by over 71%. So clearly we are making progress. We can say categorically today that people are waiting less long for their care in Leicester than they were a year ago. I believe I'll be sat here in 12 months' time saying the same thing to you, because I think we have the capacity in place and the programmes in place that will allow us to continue that. That is notwithstanding the financial challenges and other challenges we face as an NHS, but I believe we do have that in place. And you can see quite clearly in the charts that after a period of years of our waiting list going the wrong way, we have turned a corner, and we are doing so sustainably. Urgent emergency care we often come and talk about, so I'll not dwell on today. We know it's been a really challenging winter. We've had really significant increase in admissions through our hospitals, but again, every month in 2023, we had fewer ambulance handover hours lost than in 2022. We now need to build on that progress alongside the challenges which we're facing with increased admissions through our hospitals. Finally, and it's not directly linked to this, but we were also asked, in fact, just to summarise that one again, because one of the questions that we were asked before this was, how does it align the improvements we're seeing with our overall position? So we are one of the biggest trusts in the country. We do have one of the largest waiting lists in the country. We had one of, if not the largest growth in our waiting list during the pandemic, for various reasons which people will know across Leicestershire. So that absolute position does put us, and it still puts us, in a very challenged position. However, we are making significant progress in reducing that waiting list now, and hopefully you can see that very clearly in the slides that we present today. We were also asked, about the critical incident we declared as a system and as a trust in January. And so in the final two slides of the pack, we will just provide a brief update on that. So firstly, the first slide just summarises how this works in the NHS. So we know we need to respond to a range of incidents and emergencies, and broadly they're categorised as business continuity incidents, critical incident or major incident, depending on the classification of what is happening within there. On the 23rd of January this year, we took a decision as a trust and as a system jointly to declare a critical incident. We had discussions into the evening and discussions in the morning that said because of the position we were in, we needed actions to take place that could be triggered by declaring a critical incident. That doesn't mean we weren't challenged at other points during the winter at various points, but there were specific things that we wanted to enact due to the pressures we were facing at this time. We had response from across the system and from partners across the system, including Leicestershire Partnership Trust, social, local authorities, to support us in recovering our position there. And we were able to step down the incident in 52 hours and 3 minutes. We were very specific about that in the paper. Again, it doesn't mean it fixed by that point, but it meant it put us in a position where we didn't think being in a critical incident was adding sufficient additional action or change at that point. I can't sit here today and say we'll never have critical incident again as a system. There is large variation in our urgent emergency care pressures. What I can say is we as a trust and as a system acted absolutely in partnership to make sure we did the right thing for patients during those very difficult times. And we certainly were not alone as a trust or a system in the country in declaring a critical incident in this winter. Rach, anything to add?
Thank you, John. I think the last point was really important. So when we did a regional analysis and a national analysis, certainly out of the biggest 20 trusts across the country, almost everyone did declare a critical incident at some point in winter. That's not to excuse the fact that we had to do it, and we are very clear as a system and my individual partner trusts that we do what we can to make sure that we're not in that position again. But I just wanted to provide that context for you across the nation.
Okay, that's very helpful. Thank you very much. We've got one question from Jeff, which is actually to do with the critical incident. So I'll take that first since that was the last item, and then I'll go to Betty, who has another question. Any other questions that anyone wishes to raise at the moment? Ross, Melissa, Brenda. Okay, I'll take those in those orders. So Jeff first.
Thank you, Chair. I was myself a visitor to the accident and emergency unit at the LRI on the 24th, the second day of the incident, and I was quite shocked at the general condition, with a couple of hundred people waiting, a lot of people having waited 8, 9, 10 hours. The staff were obviously very stressed, huge queues of ambulances outside, even a queue of police cars. I just wonder if we've heard the whole story about how and why the incident was declared. I've heard that it's been blamed on the cold weather, but we didn't really have a severe winter. We've not had a long period of snow with all the falls and fractures that usually result from that. The industrial action or the strike action taken by junior doctors, the latest strike was finished 2 weeks before the critical incident. And there's a lot of really significant improvements that have been described over the last year, which are documented in this report. Yet it seems we suddenly fell over a cliff. So I'm just wondering if you can cast a little more light on what exactly caused this critical incident. Thank you. Did it come on?
It's fine. Yeah. Perfect.
So I'll start. Firstly, we're absolutely telling you the whole story. There's nothing in the report, I'm just checking, about cold weather, I don't believe. Forgive me if I've missed that. We have seen over a period of months, and hopefully you can see on slide 8 and 9 of our 7 to 10 of our pack on urgent emergency care. This is not falling off a cliff over a period of a couple of days. This is a sustained period of pressure which increased up until the 23rd of January and has remained sustained over a period of time since. Probably through November, December, January, February, we saw significant increases on admissions year on year, and that level of variation caused us to have really significant pressures around the 23rd of January. probably 2 weeks before as well. We were a similar level, but didn't quite hit our criteria for declaring a critical incident. So it was not a unique event. I'm so sorry for your experience and the experience of anybody who has waited too long on our urgent emergency care pathways this winter. I'm very clear that that has happened from time to time because of the pressures we have seen. There is no hidden story behind this. Let me be absolutely clear about that, because you make that question very clearly alongside it. We are doing a review with the University of Leicester at the moment to understand why we have seen such an increase in admissions this winter, above the level of previous winters. But yeah, hopefully that answers your question. We certainly, we want to be absolutely transparent about this.
Thank you very much. Bessie.
Firstly, can I commend you on the 77% reduction on elective weights? That is pretty good and well done. But I would like to look at page 20 in terms of your deep dive. There was a report from the Chief Operating Officer, and I just wondered whether or not there are any equalities implications in terms of the deep dive, and if there are, how will you deal with them? Thank you. Thank you, Chair.
Thank you. Now, you'll have to forgive me because I've only got the paper in front of me that I sent in. Page 20, which does it have a title, that section?
It's the second page of your covering report.
Forgive me. I'm looking at the wrong pack then. It's not in the pack in front of me. So forgive me, I'm ill-prepared.
I think it's actually, is it the,
sorry.
It's the covering report to your slides.
I am with you. Sorry, I am now with you. So we are doing, this is the reference that we are making to looking at a wide review about the wider emphasis of what's happened over this winter, that will look at the system equity aspects, including where people came from across the community as well. Rach, did you want to come in on that?
So this particular action was about looking at the numbers of call volume, the call volumes that we had at that time into the ambulance service in particular. What we know, particularly in some areas of Leicestershire and Rutland, is the health literacy is much lower than some of the other areas. So what we want to look at is postcode by postcode almost. Is there a difference in what people can explain for themselves and advocate for themselves, and the length of time then that they wait for on the back of an ambulance? That, I think, from a quality perspective and an equality perspective, we must understand what we have to do differently from a call handling perspective. So this is not about translation, it's not about those types of things, it's about the ability of those call handlers to understand exactly what people are trying to explain to them across the diversity of communities that we have across Leicestershire and Rutland. That's the deep dive that's been requested by the Equity Committee. It's not completed yet, and as you can imagine, because of the depth of it, it will take quite some time to give us the results. But we're expecting a city report, we're expecting a county report, a Rutland report, and we've also asked for some neighbourhood reports so we can be very clear about what we are seeing.
Okay, thank you very much. Right, I think we've got Melissa next in that case. Oh, whose hand was up first? Oh, okay, Ross, and then Melissa.
If you insist, Jonathan, I'll go first. First off, I just want to congratulate yourselves and obviously the whole team and the trust as well for the hard work that you put in. I know it can't be easy, you know, work for the NHS sometimes, and it can seem like you're pulling all the levers, but nothing's really happening. So well done on producing the results. And actually, it's refreshing that we had discussions about these plans about a year ago, and we were saying, you know, this is where we want to be. So it's nice to see you come back and say, actually, you know, we're exactly where we want to be. Obviously, there's more work to be done, but we've made good progress. So well done. When we were talking about this about a year ago, we said that sort of staff are key to all the success that we're going to have going ahead in the future. Okay, obviously we've got the backlog and backdrop of ongoing strikes with the junior doctors as well, and we've all been reading in the news about the positions of physician associates or PAs. I'm curious to know what the trust's thoughts are around this and where we're going, because I've got colleagues that work for the trust, and you know, it's a difficult time right now, like I've already said, and they're concerned about where the trust will be going if you're going to place future emphasis on that position, the PAs in the future. So I'd just like some clarity on, are we recruiting more and more numbers of these? Is that where we're looking to go? Because obviously they're cheaper than hiring a junior doctor. That was my first question anyway.
Thank you. It's a good question. So you're right. Workforce is a fundamental point for us. And a year ago, I sat here saying that what we want is to recruit colleagues sustainably, so we have less reliance on bank and agency. We have seen a significant increase in our substantive workforce over the last year. We have seen turnover decrease, and we have also seen the fourth best improvement in the country in terms of our staff survey for would you recommend this as a place to receive care, which we're very proud of, and we think those points are linked. However, we are also, like any NHS organisation, facing financial challenges as well, and what we need to do is reduce our reliance on particularly bank and agency during this time, and that's a key area of focus for us in the year ahead, whilst continuing that work on culture. In terms of specifically physicians associates, we like all professions across our hospital, they are an important part of what we do. We have a relatively small number at the moment. I don't have the number on me, and myself or my medical director could come in a future month and talk in more detail around that, but it's a relatively small number. We only put them into places where they're clinically supported and absolutely in line with their competencies. They are not a replacement for colleagues. We are using them to supplement and provide continuity of care in places where it works. And you have our assurance that we will carefully, any workforce expansion in any profession, will carefully implement it. And I'd say they don't replace the need for consultants or allied health professional or other colleagues across our organisation.
Okay, thanks. My second question was on diagnostics. If we have a look at, I know we've got the same report on me where there's three sort of tables with a 6+ week, 13+ week, and overall waiting list for diagnostic services. This all generally started to go up in about April 22, and then started to come down in December 22, but they've sort of plateaued off. Are we expecting them to come down even further? I mean, I note in the report as well the fantastic news that the CDC, the Community Diagnostic Centre in Hinckley, is still on track to be open at the end of this year or first thing next year. So I presume if we're opening CDCs across the county, we'd expect this number to come down. But it does look like in the report it's just levelling off.
Thank you. Good question again. So you see, generally speaking, it will be similar with the longest wait, so 78-week wait and 65s as well. As you get down to the lower numbers, you tail off as because you get to a more complex group usually that are trickier to get rid of the final, not few, because there's still a lot of people on this list. So we kind of expect that natural as we're dealing with the bigger numbers. There have been at points over the last year where we've had short-term funding to be able to deal with specific backlogs, and that also is the case. There are still one or two diagnostic modalities where there are workforce shortages, and so within this we have significant challenging, which will be the cause of some of that as well. I am still confident overall that we'll continue to see that progress though, because of the capacity we've got in place, and indeed the capacity we will have coming in place with additional endoscopy builds and the community diagnostic centre at Hinckley.
Still my question about plateauing, Ross, so never mind. I won't ask it again. Okay, Melissa, definitely you now.
Thank you, Jen. Thank you both. My questions, I'll go quick fire. They talked about UEC, that's urgent emergency care, planned care and cancer care. They're the only things that we get tiered for ever, are they? Or are there other things? And what tier are we in for those, please? We could be in a tier for any of our big portfolio areas, for children's care, for mental health, for maternity, and so on and so forth. So we're not in any tier at the moment for anything apart from those. So we are within the parameters that you would expect from a performance perspective and a quality perspective for the other big portfolio areas that we hold.
Thank you. So when we last met, we talked about how almost 12% of the population of LLR were on a waiting list for some sort of planned care. What is that now, please? I'll ask my third question, Chair, while he digs through the papers there. My third question is that I was as alarmed as everyone to read about the 12-hour waits for emergency care on the 23rd and 24th of January. Especially as Councillor Whittle talked about, it just felt like there wasn't a huge thing. It was just an enduring kind of range of pressures. What is the pattern of these critical incidents, in spite of all the joined up working and planning that we talk about? It feels like they're becoming more regular in spite of everybody's best efforts. So when was the, so I'm sort of asking, when were the last three in terms of dates, so that we can kind of work out when the likelihood of another one is, because I know that we'd all, especially health colleagues, really like to not have that. Thank you.
Thank you. So personally on the waiting list in our public board this month, we had 108,000 people on our waiting list in Leicester. Forgive me, I can't do the maths on proportions there, but in the pack, I'll just refer back to the fact that that was at the end of COVID.
So it's about 1.15 million people in the LLR area. So that would be slightly less than 10% by the sounds of it. Slightly lower than it was by the feel of it. Yeah.
So our waiting list towards the end of COVID, or after the end of COVID, was over 130,000. So in the last 12, 18 months, we've seen it go from over 130,000 to 108,000. And we have to continue that progress. We know that that's a 16% reduction, and that's the second best in the country in terms of ICB. In terms of critical incidents, we have, again, I'm racking my brain now, in terms of UEC operational pressures, we have declared 2 in the last 2 years. One was in January this year on the 23rd, and one was, I believe, on the 29th of December 2021. Not this Christmas, the Christmas before, so I'm probably getting my dates wrong. And that's in my time, so over 2 years, two and a half years, 2 critical incidents due to this. That doesn't mean there haven't been significant urgent emergency care pressures during that time. I don't think there is any evidence that we are doing anything with increased frequency in terms of critical incident, because as I say, 2 and 2.5 years, or 2 years, 3 months doesn't indicate that. And generally speaking, we manage our pressures without declaring a critical incident.
Jeff, you want to ask a supplementary to that one? Or at the end? Okay, sorry, that's fine. Okay, in which case, Brenda, I think you're next on the queue.
Thank you very much, Chair. Welcome. My question really is for clarity's sake, for me reading the summary. So the first 2 questions would be, if you could explain going further, faster and mutual aid on the summary, please.
Thank you for those questions, and I understand that we can slip into NHS vernacular from time to time. So Going Further Faster is a programme supported by the National Getting It Right First Time team.
Oh, I wondered what that long acronym
was. As they call themselves. So this is an initiative led by Professor Tim Briggs, who essentially supports trusts across the country to try and standardise good care and get it right first time. They support us on key areas such as theatre productivity, using our estate in the best way. Last year, they created this scheme called Going Further Faster, which was particularly looking at specialties and how we can go further and faster in reducing our backlog. We work incredibly closely with the national team. We had a recent meeting with colleagues in Kettering and Northampton hospitals with the national GIRFT, Getting It Right First Time team as well, to work out how we can work in partnership to learn from one another. We are seen absolutely by them as a success story that is moving in the right direction. And for example, we can use them to say, in specialty X, what's everybody else in the country doing? Have we got our setup right for outpatient clinics? Have we got our theatre utilisation right, etc.? So it really helps us compare, contrast, and use our resources in the best way, and fundamentally bring our waiting list down. Mutual aid, is when we get support from colleagues at other trusts. So for example, if one trust has a waiting list of 5 weeks and one has a waiting list of 50 weeks, they would say, can you give us some mutual aid and take some of our waiters, if they are prepared to travel down there? It's always with the consent of people who are on our waiting list. We might ring them up and say, look, you can wait for less time down the road, would you like to have your appointment down there? So fundamentally, that's what mutual aid is.
Thank you very much. Well, they're going further faster. I'm surprised that that's not the case previously, that you actually compared and contrasted with other NHS organisations, but I'm glad you are now and finding the best practice. Mutual aid, so I now understand that. Now, last week, and I don't know whether it's because I'm more focused I've had 2 knees replaced. I actually saw the first advert that I've ever seen. Somebody advertising that they do knee replacements, and on the television it's usually focused online or something like that, and I saw it on the television for knee and hip. And of course I had mine too in a private hospital, but it was on the NHS, so thank you very much for that. And so I wondered whether there was when it was mutual aid, I wondered whether that came into it as well, using the private hospitals and being able to steer NHS patients to those hospitals.
Thank you. So there's a national initiative on patient choice at the moment. So where you go to see your general practitioner and they refer you to see a specialist service, quite often, as John says, there is variation in waiting times across different providers that are accessible to that particular geography. So what you will have seen are a series of adverts now that private providers are putting forward to suggest that in that local area, they are one of those choices that those patients could make when they go and see their general practitioner or referred for onward service. So what happens now when you go into your general practice, you'll be told that this is the specialty that we'd like you to refer into, and here is something around the choice of providers that you can go to and the waiting times that you could currently access. Some of that is live on the GP screen, some of that is via the NHS app on the patient choice, and some of those are through various means of knowing where the waiting times are for specific areas. So what we're trying to do is make sure that we can use all of the capacity available to the NHS, private or otherwise, to make sure we can get those waiting lists down, given the whole country is in the situation of waiting lists not quite being where they need to be at the moment. So it's all about expanding choice whilst helping us with those waiting lists.
Thank you very much. And my final thing is the patient-initiated follow-ups. I'd like to find out a little bit more about those, and are they successful, or are there problems with people not bothering to follow up and getting sort of worse later on?
Thank you. Just firstly, just take one step back to your previous point, if I may. So just to be clear, we compare ourselves to peers and to colleagues nationally and internationally all the time, including Quality Finance Access. The Getting It Right First Time programme is just another model of doing so with more regular support with clinical leadership and regular meetings over a period of time. So I don't want you to go with the impression that we haven't been doing that for years in different guises. In terms of patient-initiated follow-up, quite simply, this is a way that we can provide, in my opinion, better, and our clinicians' opinion, better clinical services to patients and better access to patients. So, for example, if you come to an appointment, you have been given your treatment, the clinician might say to you, we don't need a fixed follow-up, but if at any stage in the next 2 years you need to follow up, get in touch and we will find you an appointment, rather than you're definitely coming back in 6 months, at which stage you might not need to see us, but you might need to see us in 9 months, at which stage you won't have an appointment. That doesn't work for every specialty, because some will need you must have a 6 months follow-up. This is absolutely clinically led. It's what is the right thing for patients. We think it is an area where we can continue to improve and provide better service for patients, better use of our resources so people aren't coming for an appointment when they don't need one, and better patient experience as well, fundamentally. So it is an area where we're growing. Around 5% of our activity at the moment is on patient-initiated follow-ups. We would like to grow that, but it absolutely will be clinically led, and it will not be me saying this is what you should do. It'll be them saying this is the right thing for our services, and it will be with the opinions of patients really clearly fed into it. The feedback we've had so far is very positive about it because of that freedom.
Can I just ask a very quick follow-up, actually? In the line above the patient-initiated follow-ups, it talks about length of stay for hips and knees, and this is obviously a point that Brenda raised. the stay has dropped from 4.5 days to 2.8 days, and that's in the space of only just about 12 months. So that's quite a significant change. Is that a national change, or is that something they initiated in Leicestershire? It's quite a dramatic shift in a relatively short period of time.
If I can just interject there, I stayed 1 day and it was fine.
Brenda, forgive me, that is what we aim for. Joking aside, it's a really important point, this. So it is better for patients, it's better for our services. We can get more patients through if we mobilise people quickly and they're able to get up and home after surgery. We challenged our teams a year or so ago that our length of stay for hips and knees was too long. We used the Getting It Right First Time data that says, look, compared to your peers, now we are one of, if not the best in the country for this. And it's seen as, again, a real area of success for us. I think we are the strongest in the country in December in terms of our length of stay. Absolutely, it is better for patients to get them mobilised. Their recovery is better. The evidence shows that. And so these are the types of areas where our clinical team should be very proud of the improvements they've made.
Thank you. Right, in the list. Ramsey, I'll add you to the list. We have Dan, you're already on my list. So we've got Jeff. Oh, are you sure?
Yeah.
There we go. Right, Brenda, there you go. You've ticked, you've answered everyone else's questions. So in which case we are on Mike, followed by Dan, followed by Ramsey. Okay.
Thank you, Chair. I just want to commend you on the direction of travel. It's positive. Maintain it, please. Keep it going. I can give you some user feedback. Sadly, my stepdaughter went to A&E a month ago with a suspected heart attack, went to CDU and then eventually got on a ward. That took a period of time, but it worked and she was quite happy. She was in the right place with the right people, and it waited a long time for diagnostics, but it all seemed to work to me and to her. I was astonished at the number of people in CDU, number of staff, outnumbered the patients hugely, which was a very positive sign for me. There was a huge amount of work going on in there. I'd never been in there before, but it was very interesting to understand this and my experience there, well, her experience there. So that was interesting. You said you're doing some more work with the University of Leicester about the critical incident. I would have thought you knew by now, because A&E has always been a hotbed for years now. I thought you would have known by now why people are there, and you would have had that data. Even if it was just a pie chart you'd present to this committee periodically, what percentage of people are there for what particular reason, and how you mitigate that before some of them actually possibly need to be there or elsewhere.
Thank you.
I just thought that would have been there. I've been to A&E several times and had minor things, and of course you wait, more important people come along all the time. So I've been there 8 hours, but that's the nature of the beast as I understand it. But if you'd had a full set of staff, would this critical incident have happened?
So a few questions in there. I'll try and answer. Firstly, I'm really sorry to hear about CDU, and I hope she's okay. We're very clear about our staffing ratios. We use evidence bases that are nationally transcribed. It is not feedback we've had before, to be honest with you, but I will take that on board and I'll speak to our chief nurse and medical director about your feedback to that end. Our first job is to make sure our services are safe, and I hope you saw that. In terms of the review, I hope I'm not misrepresenting this. We absolutely understand our flow day in, day out. We know every patient that leaves, comes, why, what the procedure they're here for, etc. What we're talking is more broadly, it's not about the critical incident, the review is more broadly around this winter. We've seen significant increases in admissions. Where's that coming from? Whereabouts in Leicester? Is there any particular conditions that we need to think that influence our commissioning strategy? I will pause there to see if Rach wants to come in to pick up that.
Thank you. So really interestingly, we can give you data about who's coming from which postcode, from which practice, down to lots and lots of individual bits of data points. What we're asking University of Leicester to do is understand that over the last, since 1920, we've seen growth, but managed growth across the emergency care pathway. What we've seen this year between 22-23 and 23-24 is growth that we haven't seen before. So we've got a higher level of growth for both A&E attendances and for emergency admissions than we have ever seen in this system. So if I go back to 1920, year on year, we've seen about 1.5–2% growth, which you would expect due to population changes. This year, just looking at emergency admissions, we've seen almost a 7.5% growth just compared to last year. Now, we didn't model for that, and what we want to understand is the root causes of what's happening year on year to make that happen. The other thing, of course, is that we need to get ahead of some of this so that we're not in the same position again and again, which means different models of care and breaking down some of those barriers between primary care and secondary care and providing care in a different way. As you've just said, when you've got an ambulance called for a specific condition, does it have to go to CDU, or is there a better place for it to go to, so on and so forth, as well as the prevention agenda, which we've talked about multiple times with our HOS colleagues about doing much more in that preventative space and preventing people from getting sick in the first place, or managing conditions in a different way so that they're not ending up in crisis. So that's what the University of Leicester work is, a real in-depth view of actually what we can do looking forward for the next 20–25 years.
Forgive me, sir, I forgot your final question. I didn't write it down. Did we?
If you've had enough staff, I mean, I've got the ONS workforce modelling thing here, which has just been released, and it doesn't shine a particularly good light on the modelling going forward. But I just wondered if you'd had a full set of staff, would the critical incident have occurred?
I believe it would. There was, in our after action review, we showed no evidence that staffing levels were contributory to the critical incident.
Okay, thank you very much, Michael. Dan, I think you're next on the list.
Thank you very much, Mr. Chairman. I'm interested, I spotted about your surgical robots, and I'm interested in the part they play. And obviously, before I left home this morning, there was this satisfaction survey on the National Health, and it's at 24% satisfaction. And that is the perception of the public. But what I'm trying to get across to you is that we here, as representatives of the public, have often commented about some of the activities going on and what we see, and to ask questions. So the pressure is on. I mean, you're doing well in lots of ways, but it's nowhere near good enough because the satisfaction's down there, and you've still got a mountain to climb. So I'm always supportive, but I want to be only critical where I think I should be, and people have told me that there are their concerns. So it's something that just absolutely landed on the TV today, just before coming out, and I thought, wow, how appropriate for today. This survey is brilliant. Unfortunate for you, but good for me. Not to be arrogant, but to say, look, there is this pressure that we talk to you about from time to time, how people are performing. And as well as you're doing, you have to do more, and you have to work hard all the time to stay at the top of anything in this world, whether it's professional or sport or whatever it is. You've got to work hard at it because there's a relentless flow coming your way, and that flow will never stop, I doubt, for 1 minute. You're trying to regulate now through good ideas of thinking and surveying. Can we work out where the volumes are coming from? So you have a lot to do. But anyway, so it is a concern, and I'm just letting you know that 24% people do talk to us, and that's what we do, represent people. So when we read stuff, we understand, because of people are saying, well, we can't do this and we can't do that. But apart from that, it's the robot intervention that I can remember reading some time ago, that perhaps that was going to sort of really change the whole world of surgery, because the robot would be there and they're a lot easier to run, and The cost probably is different to a surgeon, and the training time, if you haven't always got the surgeon appropriate. I don't know, but that's the question. Can you explain what they do, and do you perceive them being a growth in the future? Thank you.
Thank you. Excuse me. To address the robot, first of all, so we currently have two what are called Da Vinci robots at University Hospital of Leicester, one at the Leicester General Hospital and one at the Leicester Royal Infirmary. The Leicester Royal Infirmary one came in October 2023 and was kindly supported by the Samworth Foundation with a charitable donation, for which we are incredibly grateful, and wouldn't have been able to make it happen without that. They are still expensive, they're not necessarily the norm across the NHS. We had the opening 2 weeks ago, and I was lucky enough to speak to two patients who had the first and one of the early procedures on the new robot at the Leicester Royal Infirmary, and they talked about the fact that their length of stay in a hospital was significantly shorter. They had avoided, as a result, months of chemotherapy. They were back at home with their family. One of them was just going on holiday. You know, it's the patient quality, the outcomes for patients, the experience of patients is absolutely changed by having the right procedures done on these surgical robots. That said, it is still a very, very small proportion of procedures we do across University Hospitals of Leicester. It's only 2 robots. In the years to come, we would like to expand that. Our next ideal would be to have one at the Glenfield Hospital for appropriate procedures. We're working up a case for that now that we might need support with, but there will be the development of robotics program in the years to come, and we'll make sure that matches across the region as well to make sure we give patients what they need. But it is primarily a patient outcome and a quality thing that the robots are driving. As I say, we're very grateful for that support. We want to be at the forefront as well, and we're clear that people want to come and work with progressive organisations that are making moves in things like robotics as well. So it's an important part of that. In terms of the satisfaction piece, if I'm honest, I've not read the detailed stories yet. It's been a busy day, but it's a national picture from looking at the headlines on this, and I'd love to see the Leicester picture on that. We have recently had our staff survey for UHL, as I said, which shows that we are making progress. I think on 90, I can't remember the exact number, it was over 90 of the 106 questions we'd made progress over the last year in terms of our staff's response. But clearly patient experience is a key part of that as well, which we get feedback on and report regularly. Like you say, I think we are humble, we're proud of what we're doing. We work incredibly hard at what we're doing. We do it for the patient. We do it for patients and colleagues. That's it. That's why I come to work every day. I know the same is true of the teams across the system and UHL. And I know people work incredibly hard, and we know we don't accept where we are, and we must do more.
Please, what sort of, obviously, I sit here listening to you doing this, doing that with the robot. What sort of surgery, what sort of procedures are these robots now undertaking?
You're testing the boundaries of my non-clinical expertise now, sir. But for example, some throat cancers, for example, they'll have for some laparoscopic surgery and general surgery, so things like hernias and many other kind of surgeries on the body, so to speak. We can happily provide a summary at a future meeting with some clinical colleagues to explain in more detail. We've got hundreds of presentations showing what it does. Equally, if you search for Da Vinci robot, you'll see all types of examples. Forgive me for that. Probably my worst answer of the day.
Just be very careful how you spell Da Vinci and robot. I think is probably the model on that. If you're searching on anything from the county machines, God knows what you might find. But if at some point it might be worthwhile actually having an update on that, because it is genuinely, I mean, it's an extraordinary, a bit like, you know, the hip and knee procedure changes. I mean, it's things like that that actually have a step change in the way that health provision moves. Ashna.
Just on that point, Chair, I mean, you know, we come here on a monthly, quarterly, regular basis to talk to you about some of the stuff which is not necessarily always going in the right direction. We don't spend anywhere near enough time telling you about all the thousands of things that we are really proud of and are going right. I mean, I've just had a quick look at some of the stats that we've got for some of our most vulnerable patients who are in our care homes, for example. Some of the work that we've done collaboratively across the system this winter has meant 15 less patients going into hospital and being looked after in those care homes themselves, which, you know, it might not seem like a huge number when you think about how many care home beds we have across Leicester, Leicestershire and Rutland, and the experience of calling an ambulance, waiting for an ambulance, being on the back of an ambulance, going into A&E. It's not what our patients want if it's not the right thing for them, and providing that care in the place that they call home is really, really important to people. So, you know, we don't tell you anything anywhere near those types of things, but just assurance that at some future state, if we do want to talk about some of those, you know, real celebrations of proper quality patient care that we absolutely know we've got right based on that patient feedback, we'd be happy to share some of those things with you.
It's a good offer, actually, and maybe we'll take up on that on the basis of, I mean, it may even be actually a visit maybe to LRI and actually to maybe, you know, see some of this in practice. Well, maybe we can pick a quieter moment, maybe, I don't know. I mean, I'm sure there must be quite a bit. It's maybe in the canteen in the corner somewhere.
Christmas Day.
Christmas Day, there we go.
We, joking aside, we would be delighted to host colleagues around our emergency department or anywhere we wish to go.
No hip hops on the day, please. Okay, but I think in genuine, I mean, I know there was a discussion about, I know the city colleagues have had a visit to up at the new centre, I can't remember what the new centre, East Midlands, there we go, planned care. I knew it would come to me eventually. Thank you very much, Ewan. I mean, actually, those sort of visits do actually bring the realities of the health service and the way that your colleagues provide care in a way much better than actually being able to sit in a room here at County Hall. So, you know, maybe it's something that we can actually look at as a way of, yeah, I mean, maybe even whether it's actually in advance on a future meeting, and maybe we can sort of steal one of your meeting rooms to actually host a joint HOSC afterwards. Feasible, Ewan, or not?
There'd obviously be webcasting issues that so it may not be feasible. But
well, we'll investigate options. We'll investigate options. Okay, look, we've got one more question, I think, which is the last. Janet, do you want to come in first, and then I'll go to Ramsey?
Yeah, thank you. It's just very quickly, two sort of observations really that I think are quite important that I should tell you what the patients are saying. The first thing is that we constantly hear from people that once they actually get in front of a medical professional, it's brilliant. It's getting through the treacle, the bureaucracy, getting hold of the right person to speak to get the appointment, etc., which is so wearing and so tiring. So I'm not sure what your training your staff, your admin staff have, but that is where we're hearing that there is a big problem. So that's my first thing. My second comment is that Healthwatch Leicester, Leicestershire and Healthwatch Rutland actually visited your ED department doing what we call an interim view in September 2023 and in August, September 2022. The reports are online. They're certainly on our website, are they?
Yeah, it will. The recent visit will be in
it's
next week. It'll be on the website.
You can see we went back in 2023 to make sure that the recommendations that had come out of patient experiences and opinions had actually been enacted, and we actually found that there was a greater rate of satisfaction, and quite a few of the recommendations that we had made had been taken place. That we still left with you with more, but and we still found people that had been waiting a long while, but generally it was a more positive report than 2022, and I would urge colleagues to read that report. It's a joint one from both organisations.
Again, thank you for taking the time to do the review. I've read both reports in details. We have action plans around them, which we monitor with the team who are responsible for the emergency department and medicine, and they're very important to us. So we take them very seriously, and thank you for doing it. In fact, we were just looking at the action plan last week, so I can assure you we take that very seriously. We're very grateful for your support. The first side of things, you're right. We do know for certain of our services it is difficult to make contact. We are trying to make things easier. We know digital will be a key part of that solution as we continue on our journey of becoming a more digital organisation. And that includes things like digital phone lines to allow us to route calls better. We are doing some of the basics as well at the moment, which is about making sure we've got all of the right contact numbers for every service throughout the hospital as well. And we've also rolled out something which we allude to in here, Accurix, which is about texting and allowing people to rearrange appointments through text, which again means that people don't have to wait and try to get to the right department on the phone. But do I think, if I'm honest, there is somebody right now ringing up our hospital and struggling to get in front of the in touch with the right department? I do, and I'm really sorry for that. We know we've got a way to go. It's not going to be an overnight thing, but I can absolutely assure you it's a real high priority for us. I do think it's better today than it was a year ago, but that's the journey we're on.
Just to enlighten you a bit more, out in Rutland, we're actually planning to do a sort of research project looking at the patients' communications with the NHS. So between yourself, hospitals and doctors, and where the patient fits in with that. So it's quite a lengthy and complex exercise. So it'll be some time, but obviously happy to let you see it.
Janet Ramsey.
Could I reciprocate the comments of my other colleagues about the improved performance that we've actually seen? I've got one specific question, and then there's another topic that I'd like you just to expand upon, if you will. The first one relates to the electives delivered, and specifically the 0-104 plus weights. Is that number actually correct? And before you answer the question, I actually have a note from a constituent whose husband did not experience that 104. So it's about out with that. So it's just a question about the accuracy of that particular number that has been presented to us. So, do you want to answer that, and then I'll ramble on?
So yes, it is correct. To all of my knowledge, it is absolutely correct. I am aware that, well, if the person would like to get in touch with me, we'll absolutely look into his pathway. And I'm so sorry, or their pathway. I'm so sorry that they've had to wait that long for care.
I'll pass that on, and thank you for that.
Absolutely. And what I will say though is there are national rules which we must stick to, and we are absolutely strict on, that define when you can stop a clock, so to speak. I don't know.
No. And this was as at the end of December. So let me just continue. This is really about capacity, and you'll recollect that in February 20. Sorry, I beg your pardon. You'll recollect in February 2023 there was a plan for improved utilisation of community assets, and on page 27 there it talks about a year of improvement working through to create community capacity, and then in the summary you again list the activities that have taken place with regard to adding additional capacity. Could you just say a little bit more about the progress that you're actually making in this area about effectively improving the utilisation of our assets? And just before you do, I intend to come back to this subject, Chair, in a further a later agenda item. Thank you.
If I start on UHL community assets, then I'll hand over to Rachna. So we at UHL have sites. We have 3 of our largest sites, and we also have many community sites around as well, which we operate out of, particularly with elective care. All of those have operated under the same programme that we've described in terms of improving our productivity, improving our utilisation. And as we've grown our activity levels, we have grown our clinics that are outside of UHL as well. Like everywhere, we have further to go. Sometimes it is difficult with staffing to get colleagues out, etc. We had a summit. We had a meeting with community colleagues across UHL last week, which said, well, what do we want to do in the year ahead to continue that progress we've made in terms of utilisation, growth of outpatient activity, etc. We do still have some variable weights. For example, some of our community sites might have a different wait time to our larger acute sites. we know we've got to move to one waiting list across all of those. That is a fundamental point for us in the year ahead. And our Director of Planned Care in the system, Helen Henley, is working incredibly hard on this as well, as a key priority for the year ahead, to make sure that we are utilising all of our capacity across the system incredibly well. And that fits very neatly into the planned schemes, such as the Community Diagnostic Centre at Hinckley, to make sure that we're fully utilising those on day one. So again, I think we can evidence that we have seen progress there, but we still have a way to go to improve some of our utilisation of those sites.
Thank you. Betty, I think you've got the and Trevor. Oh, gosh. Right. Anyone else apart from Betty and Trevor? No. Perfect. Right. Betty, then Trevor.
It's looking through all of those incidents that you have there. You've got critical incidents planning, critical incidents, etc. And you talk about the increased demand due to the number of people waiting, the volume of people waiting, and long ambulance lists and waits. I just wonder what more can be done to decrease these demands, to perhaps maybe to encourage people maybe to go to the doctor more than going and attending the hospital. Some people just turned up to the hospital instead of using the doctors. What more can be done to mitigate against that? Thank you.
So you won't be surprised that is the vast majority of the conversation that John and I have on a day-to-day basis. So part of this is taking all of the learning that we've got from our patient experience surveys. So a lot of the surveys will tell us, for example, when we try to get through to the doctor or we can't get through, our next stop is A, B, C, and D. So there's a lot of that demand. There is a cohort of patient then who will try 111, for example. They'll phone 111 and the length of time will be too long for them to, in their eyes, wait for what they see as urgent. Therefore, they'll walk into the emergency department. There'll be a cohort of patients who phone for an ambulance. The ambulance is going to take too long, so they will turn up at it. So it's about making sure that every single one of those access points that we've got has got enough capacity, so enough staffing and enough phone lines to be able to take that, the demand that we've got, but also that we've got enough places then to be able to send people. So this year, for example, we launched the acute respiratory infection hubs out in the community because a lot of patients were turning up both at the children's emergency department and adult emergency department with very mild asthma. But because of the weather conditions and things that we had at the very beginning of the year, we were seeing more people turn up at the emergency department. When we put those hubs in, and whether you phoned the general practice or whether you phoned 111, you would be booked an appointment in one of those hubs rather than going to the emergency department. So we've got lots of evidence now that that type of thing works. So what we're doing is making sure we've got enough capacity to answer the phones and then enough capacity to provide an appointment which is convenient to that patient. Now, the convenience part is something that we need to work on. So we can't always provide the appointment in the nearest place for that patient. So it's about making sure we've communicated to that patient that these are your choices. And you know, the very last choice is go to the emergency department. We've got to make sure we've got plenty of other places that people can go. By and large, we are planning already now for winter 24-25 and 25-26 in that very vein. So how do we create the capacity and how do we direct people to the right place the first time so they're not bouncing around the system?
An issue of educating people about where is the most appropriate place to go. The hospital isn't always the most appropriate place. Sometimes people turn up there because that they can't get an appointment with the doctor or whatever. But it really, what can be done to reduce the numbers of people going who probably don't need to be there, that would be better off seeing their own doctor? It's an education thing, I think.
It's education of us all, isn't it? I think partly not only where to go, but also when to access which service. So you may have seen the national releases of Pharmacy First. So this is another initiative that we've put into place to make sure that the 7 most common conditions that people are turning up for in these types of environments could very simply be dealt with by a trained pharmacist. So we've got to create confidence in that, haven't we? We've got to create confidence in our local population that if you go to see a pharmacist, you will get the answer that you need to deal with that clinical condition. That's something we've got to build, and that will take some time to build. You know, I say quite often when I come here, if I tell my mum, go and see a pharmacist, her immediate reaction is, well, actually, I want to see the doctor, because that's that's what her mindset is. So I'm saying to actually the pharmacists that we've got now are very different from a generational training perspective, and they've had additional training. They know what they're doing. Go and see pharmacists, see what we can do. The other thing that we've got though built into that is if the pharmacist can't deal with you, you should be able to book an appointment then with the person who can. So again, you haven't got people trying to access one door being closed and then trying to access another door, which just adds to the frustration, as Janet beautifully put it, the treacle of trying to get to the right person. So it's about making sure we can put as much of that in place in a way that our patients and our population and our residents understand, which we're still working on and will be an ongoing process over the course of the next couple of years.
Fully understand everything you're saying. I think one of the problems is really educating the public out there. I mean, I locally have an absolutely brilliant pharmacist, and quite often people go to him before they go to the doctors, but it's actually informing people that they can do that. They can go to the pharmacist and reduce the waiting list at doctors. So I was just wanting to know what more can be done to encourage people to go down that route. Thank you.
So we've got a national campaign, we've got a local campaign, and we would seek your support as well in terms of actually spreading some of that information. I know we've done this previously with various local councillors as well, to make sure we are using the networks that you guys have as well to make sure we can disseminate that. But there is a communications package that has been launched locally. I hope you've seen it. If not, I'm sure my comms colleagues will be happy to share some of those big headlines with you. But the national campaign started 3 weeks ago, I believe. And is due to roll out for the entirety of summer in preparation for winter.
Absolutely. Hopefully they will start feeding back into some of the figures at the hospital. Trevor, I think you are the pleasure of being the very final question.
The last man standing. Thank you, Chairman. I again reiterate what everyone's said around here, how fantastic the moves and what you're managing and bringing down the numbers on the waiting lists means to us, because it really does. What I'm looking at though is your funding, and I'd like a little bit of information, if you can give it, as to precisely how you're managing the various pieces of money and funding which are coming to you. Because can you disaggregate the existing annual sort of funding with additional funding from government, with emergency funding, with COVID funding? And what do you see with those types of funding models? And you make the cases to get that from government, of course, as an NHS. What the dangers, future dangers, might well be, and how on earth do you build a contingency, or don't you, in that, in terms of your growth agenda? Sorry, Chairman.
So I don't think it's any secret that we are financially very challenged as a system, regardless of which of my providers you look at. Overall, we are overspent. Your question very specifically there about how we can disaggregate some of those budgets. Some of the work that John's presented today has been made using external funding on top of the funding that we get as a baseline. So there is something called the Elective Recovery Fund, which was launched 2 years ago, 2.5 years ago by the government, which effectively tells us that if we perform to our baseline, so the numbers of patients that we said that we would see in our operational plans, anything above that, we can use the Elective Recovery Fund to make sure that we've funded. So some of the reductions that you've seen here are directly as a result of having that additional funding in. The Community Diagnostic Centre, of course, that's also additional funding. So we've got a baseline of what we would expect through our normal funding, as you put it. The additionality is coded and counted very differently, so we can show the value for money. So every pound that we receive, we have to send back those assurance reports. So they are disaggregated quite neatly, actually. The bit that's not neatly disaggregated is the emergency care side of things, because of course we've got so the complexity, which I know you're aware of. How do you disaggregate that? You just can't. So I've got the primary care budget, I've got my Home First budget, which is all of the community care side of things. You've got urgent treatment centres, you've got the emergency department, you've got the bedded capacity, you've got all the work that we do with our local authorities on pathway 1, pathway 2, pathway 3 discharges. It's all wrapped up into the same kind of emergency care funding bundle that we have. We are trying to disaggregate that, but as you can imagine, there is a little bit of me that says actually what's the added value in disaggregating it, unless we are shifting resource from one place to the other. Now that's where the University of Leicester work that we talked about earlier comes in place, because if we can show that over the course of the next 3 or 4 years, for example, we would expect less of this to happen here and more to happen here, then we need to move the resource, whether that's people or whether that's money, is a different thing. So it really depends on which part of the jigsaw that we're focused on. But to give the assurance to the Overseas Scrutiny Committee, there are millions of spreadsheets that we complete on an annual basis to give the assurance back about value for money. And the business cases and the strength of our business cases actually locally, I think we're one of the only systems in the country that's had 3 or 4 capital schemes approved in the way that we have, because of the strength of those business cases and the delivery that John has talked about today. So we're building confidence with that national team to invest more in Leicestershire and Rutland so that we can then provide the results that we have been looking at.
Chairman, that's brilliant. I know we said years ago when I go back a fair way on this committee in a previous incarnation, we were worried that you didn't have the facts and the figures. And what I can say, I'm so heartened to see this time I've managed to get back here, that you do have the facts and the figures and you're using them, which is most important. I know facts and figures add a bit of treacle, but you know they're necessary, because otherwise you can't make progress. And so that my final sort of plea is, can we make sure that in gaining the treacle, the IT doesn't get in the way of the rapid treatment paths? I think that's the key now, as I see it in most of the things that we need to enable in our NHS, including the NHS apps and everything else, which are great. So if at some point, Chairman, we might ask a question about that and maybe ask for some sort of paper on that as to how you do manage to gather the treacle, that would be very useful. Thank you.
Rather a lot of food allergies today. I'm more of a jam person. Jam today, jam tomorrow. So we shall see. Look, thank you very much, Trevor, for those points, and also thank you for the two of you. I mean, we absolutely get the you know, whenever you come to this room, you're dealing with questions about things that maybe are not great or have maybe not gone well. There are thousands of events every single day that you are too well aware of, where things have gone incredibly well, and lives have been saved and lives have been changed. And that's, you know, for all of us, that's the bit that we also need to remember. You know, it is heartening to see a report clearly going in the right direction, and I know how hard you have been working over the last couple of years to make sure that direction of travel has probably exceeded expectations. I think when you came here a year or so ago and actually talked about some of the reductions that you were planning, I think probably the cynicism was probably not hidden too well. It's good to actually see that direction of travel has been held, and hopefully we'll carry on. Going back to some of the non-food points, you know, the plattering, I think is clearly something that from your perspective, and I think from ours, you know, it's great to actually see the advances, but actually what comes next is obviously going to be even harder, but and just as essential. So I look forward to seeing you back soon. Hopefully with a few more facts and figures, hopefully with a bit of jam and a bit of syrup, and we look forward to seeing future advances, and thank you very much for coming today. Thank you. Right, so we now move on to item 8, which is the LLR Children and Young People's Wellbeing and Mental Health Update. I think we have Justin and Victoria, is that right? Excellent. So thank you very much for joining us today and or this afternoon. As you've probably heard, we take all the papers as read, so everyone's had a chance to read and think about the content. But by all means, if you want to use the next 30 minutes, a couple of minutes or whatever it is, to draw attention to any particular points or highlight anything that you think is something that you really want to draw to our attention, more than maybe the report does justice, please do, and then we'll open to questions and any points. Also, can you actually just remind you, I don't think I actually have on my notes so Justin, I think you're ICB, is that right? As an organisation, Victoria, which organisation you're?
So I'm the CAMS Service Group Manager.
Fantastic. Okay, absolutely. Okay, so that's great to hear. So that helps everyone to actually direct questions probably to the right person as well. So that's great. Okay, so over to the two of you if you want to draw out anything particular, and then we'll open up to questions and points.
Thank you, Chair. So I'm Justin Hammond. I'm the Associate Director for Mental Health and Learning Disabilities at the ICB. You asked us to come today to talk about children's mental health and wellbeing. So what we've tried to do in the report is just reflect the breadth of activity and the range of services that we provide to children and young people across LLR. It's really important to re-message that this isn't just about CAMS, that CAMS is actually just one part of a much bigger picture, and CAMS is the specialist element of mental health for children, but there's a lot more involved and a lot more services that we commission that do a great job and actually prevent a lot of young people from having to go to CAMS because they've got in at an earlier stage. We would previously have called that prevention, but actually now I think it's just part of a continuum and ensuring that we get the right place at the right time for those young people. Over the last couple of years, we've seen a significant expansion in some of the services that we provide, including some of the organisations that getting early around crisis, some of those that help to support children in schools, and that's a rolling national programme that's growing ever more. So we've got nearly 50% of schools now covered across Leicester and Leicestershire, with Wave 11 coming on board. We've got a triage and navigation service, which is really important for us because that service actually offers the young person and the family the opportunity to self-refer rather than having to go through a GP. And what the triage and navigation service then does is looks at the needs of that young person and ensures that they get to the right service. What that's done to impact on CAMS is it's reduced the number of young people that are going through to CAMS, and it's reduced the CAMS waiting list. And that's really important. When you need support, you need it at the right time, not having to wait for too long. We also commission a range of services from the voluntary sector as well, including the harmless service. That's the only service that we've got across LLR that supports young people and adults with self-harm, which again is really important in terms of being able to hopefully prevent further harm or eventual suicide. We've referenced in the report as well that we are actually listed as 5th out of 42 ICBs across the country for our performance with children's mental health. We've improved month on month. So again, we're really pleased with that. Lastly, we've listed down some of the services that you provide, because I think it's important that you understand that this isn't just about health. This is local authority and health and the voluntary sector doing this together. So thank you, Chair.
Thank you very much. So I'm going to go to Jeff for the first question, because I know there are a couple of questions that we've been talking about for you. So Jeff, do you want to go first?
Perhaps I give more of an update than a question, really, but it might lead to questions from others. At our recent health scrutiny, we had a discussion about access to CAMS and the pathway for GPs to request access, because we were getting reports that a lot of the referrals were being rejected through communication issues, which ties in with the comments that Councillor Pendleton made about making sure IT doesn't get in the way of effective service delivery. The current system is that GPs are required to fill in a form on the, it's a PRISM system, and that goes to DHU Healthcare, where they triage the applications. And we asked for numbers which were being rejected, and we were quite shocked by the high number. I think it was something close to a third. And so we had a further meeting, which the clinical leads from ICB, LPT, and GP practice kindly came along together with a representative from DHU Healthcare, and we had a really in-depth discussion, and we made a few notes really from that meeting. One was that we need to change the language, that the referrals were not being rejected, they were being sent back to the GPs for more information. And we did talk quite a bit about that process. And it seems ideally you would want DHU to be able to ring the GP and say, we need this information before we can safely triage and refer the the child to whatever service is most appropriate for their needs. At the moment, the process is that the DHU send a request to the GP via the System 1 service, which most GP accesses have access to, saying what information is needed. I think it was the ICB which, perhaps I should be asking how they're going to respond to this, but the ICB did undertake that they would monitor a number of referrals which have been sent back for further information to try and identify whether there were local issues with a particular PCN or particular surgeries, and to also identify what the issues are and what constitutes good practice. And a further report will be coming to the City Scrutiny at our April meeting with a report to follow. So I think I'll leave it there for now. Thank you, Chair.
Thank you very much, Jeff. That's very helpful. So on the update points that Jeff just mentioned, are there any sort of feed-in points that the third sort of referral back to rather than rejection, I think is quite interesting. And I mean, is there a pattern to some why some of those are being referred back to other? I mean, as Jeff mentioned, is it sort of a change in language, or maybe some of the forms that means that actually fewer of those are being referred back for additional information?
I'll start and then I'll ask Victoria to step in. So firstly, this is around the quality of the information provided by the GP. So a lot of the time the GP isn't providing sufficient detail for triage to be able to understand what the need of the child is. So therefore they're having to go back to the GP for further information. What we committed to, which wasn't for April, it was for June, is to do a deep dive audit on those returned referrals back to the GP to understand why that's happening in the first place. And then secondly, to understand whether those have then come back to triage and navigation. Our clinical lead was very clear that that is a GP responsibility. If they've referred to a specialist service, they need to then follow up if they haven't provided sufficient information. Our GP clinical lead was also very clear that actually this isn't difficult, but it's just about the timing of the detail that they're putting in. They're just not putting sufficient information through. Secondly, that we've committed to doing an education program with GPs again. We've run a couple of sessions and a couple of webinars, but we will do these further to help them understand the level of detail that they need to provide in order to enable triage and navigation to perform the service that they deliver. But what's more important, I think, and really quite telling, none of the referrals that come from the young person or their family get sent back for further information, because each time the young person does it for themselves or the family, they are providing sufficient information to enable triage and navigation to significantly refer straight through. So it's quite a telling picture, really. And this is why the National Children's Commissioner was so interested in the work we're doing, because actually other areas haven't provided the self-referral, because other areas are worried that there's going to be a lot of young people referring through and it's going to be, as they described it, a tsunami. But actually what we've seen is a steady flow, but more importantly, it's quality time and therefore quality output, and therefore those young people get a timely response far quicker than if they go through the GP. So there is a bit of a picture there for us, really. Don't know if you want to add anything.
Only just to say, in the last few months, we've placed some CAMHS mental health practitioners into some PCN networks, and we've increased our consultation to some of our GPs as well. So we're really trying to work with really positive ways of communicating so that we can stop some of these experiences for our families as well. So our mental health practitioners are sitting with GPs when they see families as well, and supporting alternate signposting rather than just a CAMHS. So we're hoping to progress that over the next few months as well.
Fascinating. The sort of trust the patient, and you can tell from a clinician's viewpoint there's slight sort of trepidation. Well, but actually to have sort of proven case studies that actually it's more effective to actually be able to collect that information directly from the individual rather than actually going through a third party is absolutely fascinating. Okay, Melissa, do you want to follow on?
That is really interesting. Trust the parents too, right? Interesting. I'm not saying it's the middle of the Easter holidays and that I've got 2 small children, but my question is about how we support parents and carers while they endure these waits with their children. I'm just
I just think for some of them it must be really distressing and really quite desperate at times. So what support is in place for those families, please? Because obviously that's in addition to, I guess, the front line of parenting. And then my second question, if I may, Chair, thank you, is that when we spoke before, it was clear that there was some kind of some issues because assessment processes for children's mental health at large is also where everybody's going with neurodiversity as well, and that the challenge in diagnosing and assessing everybody, that's delaying everything for everybody. I think people with neurodiversity issues are not being assessed and diagnosed quickly enough, and then getting the support that they need in school and elsewhere, and that children with mental health are then also enduring longer waits. What can we do about that, and how do we go about separating those two out a bit more? Because I get that there'll be areas where they intersect, but for surely the majority of people that they don't really in the long term. So that's my second question, please. Thank you, Chair.
Absolutely. We recognise this is a huge challenge across not just CAMHS but community paediatricians as well. So we've recognised since COVID, I think there's been a 67% increase in our referrals for neurodevelopmental assessment, and that's a national picture. What we do know is those young people absolutely do come into mental health services, but they're also a cohort that don't require us, but we are the assessing service. So we are currently, for the last 2 years, 3 years maybe, putting through a very strong business case for those young people and families to actually separate them into a single service. So, we can look at equity of those families, but we can also look at kind of them not kind of being a part of the specialist services, which can often confuse families and also not help the experience of those families. So we recognise it's a huge problem. It's an ongoing problem. We've put bids in. They're sitting with various people to look at. We recognise we've done some forecasts about what the future looks like, as well as what we need to do to manage the backlog. So it's a really worrying situation, and it does impact on our wait list for our children who have complex mental health problems, unfortunately. So we recognise it and we're looking for additional resource.
Is there a likelihood of those bids being successful, and when do you think you might hear and be able to action some of those if they're successful? Thank you.
So the first bid has been successful because that's through the ICB. So we're just sorting out the first stage of that funding now, and then that will enable LPT to provide a dedicated service. Obviously, then it's beholden on recruitment because obviously these staff aren't there yet, so there's going to be a delay before we get them through. This is a national issue, this is not a local issue, just to be very clear, and we spoke about this at City HOSC as well. We've got a regional group, which is a region for all the ICBs, to talk about the challenges that we're all facing, and there's a national committee that was set up at the beginning of the year, a task and finish group, to look at basically why there's been this huge surge in people coming forward for particularly ADHD diagnosis. For us locally, it's a challenge because the surge is way outstripped our capacity to be able to deliver, and therefore we need to be able to try and slow the referral rates through. But at the moment, we've got 5,500 young people that have come through for diagnosis, so we're not talking small numbers. You'll have seen in the news at the back end of last year as well, medication issues. So for those that are going out to the private sector, independent sector, seem to get a diagnosis very quickly and then get medicated very quickly. So as a consequence of that, that caused them problems for the medicine pipeline, and then had an effect on those people that are already medicated. So it's not a small quick fix. This is something that's going to take us many years to get on top of. We've also forecast how many years it's likely to take before we'll be able to see this plateau. And estimates are around 30 to 35,000 people are going to need to be diagnosed in LLR with a form of ADHD. So this is a significant number for us. So trying to get started now, well, at least we'll start that journey, but this will take years for us to get on top of, not months.
Can I just pick up the question about while families are waiting? Is that all right? So we've done lots of work in the last year, connecting with all the providers of emotional wellbeing support. I suppose just to mention a couple of things, we've commissioned the Solihull parenting groups across LLR, which are accessible to all our families, and all those parenting programs are in 101 different languages. We've had really positive feedback from our families. So there are things like understanding your teenager's brain, the importance of early bonding with your baby. So we've really kind of pushed those forward. And like I said, we're getting some really good feedback. In regard to if you're waiting in CAMHS, we've done lots around our digital offer. So we send booklets out now to our families as to what to do while you wait for an assessment. So we very much support signposting to other services as well. So not to wait passively for a CAMHS service, but to be really active and engaging with lots of the community support that's available. And I would like to say there's a lot of support out there. So more and more we're just trying to encourage families to think about those different types of support for their young people. Yeah.
Thank you very much. Right, we've got a few hands went up. So we've got a follow-on question from Jeff. We've then got Bessie, Ross. Anyone else? That Ramsey. That's it. Right, Ramsey, you're going to be the last question again. You're getting good at this being the last question, aren't you? Okay, Jeff.
Right. Okay. I've had this referred to me as a change in the pathway for accessing GP services, and I was asked to bring it to this committee today. So, in order to protect the patient's confidentiality, I'll obviously take their name out of it. But this is a letter that's been sent to a patient from Beaumont Leys Health Centre. Dear patient, from Tuesday, 5th of March. We are changing how we offer appointments. You will no longer need to call the surgery at 8 a.m. Instead, you can complete an online questionnaire. We will then contact you within 48 hours to book you an appointment or direct you to the most appropriate service. Please note that our reception team will no longer be able to directly book appointments in with the GP. And then it says, for more information, visit our website. And I went onto the website and it says, we are now using a total triage system to book appointments with the GP. We are asking everyone who is able to use the internet to go to the practice website and click on online consultation. I won't read the rest of it, but I wonder whether that's a single practice or whether this is something that's going to be rolled out elsewhere.
It's been introduced in Uppingham recently.
In relation, I think, to access, I mean, particularly to CAMHS services, where obviously quite often there's an urgency where something's happened, you know, to come across that type of approach from a GP service doesn't really feel as if it's appropriate. And I just wondered whether you'd actually come across this. You know, Jeff has quite clearly had this raised. By the sounds of it, Ramsey's come across it in Uppingham as well. You know, it's probably not to be, right, you've got the answer to this one. We've got the right person in the room. Thank goodness you stayed on. Okay.
There was a reason I stayed on, I suspect. So, Chair, we've received quite a few of these from various practices across Leicester, Leicestershire and Rutland, and where we are receiving them, we are talking specifically to the practice about their particular issues that they are having. So without giving you all the excuses around it, GP practices, independent contractors are allowed to, under their contract terms, put whatever kind of form of triage that they wish to manage some of the demands that they're seeing on their services. However, that said, when we're receiving this kind of feedback and we are directly talking to those practices, and I think we've had 5 or 6 of them come through over the course of the last month, those practices are changing their practice on the understanding that we've just had, which is actually if it's something that's really urgent and somebody needs to speak to somebody, filling in an online form might seem like the sensible thing to do, but not everybody is literate enough to do so. Not everyone can explain the urgency of something on an online form, and not everyone has access or can afford to pay for that level of access. So Councillor Whittle, if you wouldn't mind just sending through, I think you said Beaumont practice, again, we will pick them up. Where we are getting that evidence through, certainly our Healthwatch colleagues are helping us as well here. We are talking to them practice by practice. We've run a webinar now as well for our local general practices to say, come on now, this isn't really the type of thing that we've talked about previously. So we're trying to work with our practices to make it as easy as possible to access services. You can understand why the practices are doing it, because actually they're trying to manage the demand that they are seeing through the doors, particularly at 8 o'clock in the morning with those very long phone calls that we were seeing. So again, this comes back to as Betty was saying, sorry, I couldn't see a nameplate, was saying earlier around education and working with our patients and working with our providers to get the right balance here, which we doesn't feel like we've quite got it right here. So Councillor Whistler will pick that up with the surgery directly.
Yeah, I mean, we had this sort of conversation earlier, and the sense that there's maybe a slightly, I'll say, over-enthusiastic GP practice as far as their approach to managing demand. But it is clearly a concern when we've been talking about access that really is quite critical and quite urgent, that that then has a direct impact then on what happens when somebody has a door shut on them and they feel urgent enough that they actually then have to go to ED or elsewhere.
If I may, Chair, just to give some feedback on that. So one of the practices that we spoke to just at the beginning of this week was basically, they gave us the assurance that actually every single one of those is monitored. So whilst they say that we'll respond in 48 hours, the urgent ones are being picked up within sort of the hour, within 2 hours. But my fundamental concern with this is that's fine if you can say what you need to say and explain your urgency. It's not for a vast majority of our population with the health literacy that we know we've got. So that's the angle that we're going with the practices.
And also that they're not immediately put off by actually having to fill in, because actually the risk is that the really urgent ones are just not even bothering to actually go through the complex stage of. And as you said, I mean, there are many people who can't fill in because they don't have online access. I mean, it's interesting about Healthwatch. Obviously, I mean, one of the things that we were discussing whether Healthwatch could possibly we can apparently we can commission work from Healthwatch. So and by the looks of it, you're actually already working on this, and maybe given it's Rutland by the sounds of Ramsey's comment, and also obviously from the city's perspective and no doubt from the county perspective, whether it's possible to actually bring a report to joint HOSC on this about access and consistency of approach from GP practices across the area to make sure that we are getting best practice and that we're not getting GP practices who are maybe taking a slightly more over-enthusiastic approach to managing demand. Is that possible?
It is something that we are looking to work with the ICB on, more around the communications, and because we know that a lot of the population isn't able to fill in that form that was talked about. So actually, how do we get people to understand what the methods are to access primary care and secondary care, and how can we communicate that better?
So perhaps maybe if there is a paper being produced for ICB, maybe it can come to here as well, and then that way we get a chance to input if that's possible.
Yeah, our communications project is specifically looking at the experiences of patients with the communication as they're trying to get through the system. So it's going to be more from the focus of how the hospitals communicate with the doctors and how they communicate with the patients. So we're not actually looking at getting into the system. It's once people are. But I will pass that back.
Yeah,
and see if that we can incorporate.
It's the GP, because I mean, certainly I think probably for each of the HOSCs, and I'm absolutely assuming probably Rutland City and County probably have the same pressures, which are the commentary about access to GPs in particular, and obviously going back to Rachen's points, and now that we have this perfect example of CAMS and access to CAMS in particular, where actually one of the routes is actually you miss out GPs completely and you actually self-refer, and actually strange enough that's producing better data, and it's fascinating to see that linkage and saying actually maybe there are other ways of accessing healthcare that doesn't actually involve the problems of or perceived problems of actually getting through a GP and accessing services that way. So I suspect there's some really interesting linked up processes and practice that can benefit elsewhere. Rachen, you've got the answer to this already.
Just an example for this. So the where we are using those, and you've got a reasonable level of health literacy, and you can explain what you are requesting or what you're looking for, actually it's much quicker. So you get a direct referral, for example, into musculoskeletal services, or which is very tailored to what you need. So my problem is not with the system per se. My problem is with the safety net for those who can't use it. So where you can use it, we should absolutely be encouraging people. So people like me, if I'm confident in using that, I can express what I need. There is no reason for me not to use that system unless I've got a very, very pressing need that I've got, then I should probably be in the emergency department. But for those who can't, that's the bit that we're worried about. So that's the bit we've got to crack. But otherwise, for people who can use the system, it is much more efficient actually than hanging on for 30 minutes, 40 minutes on the phone at 8 o'clock in the morning and then not getting the appointment that you need.
Okay, so perhaps what we're looking at is actually, if there are less than best practice examples around, but I'm assuming there are also best practice, to make sure that you can capture the people who are not necessarily able to actually use the services directly themselves. So it may well be that maybe Healthwatch can bring something back on that basis, which is actually something that actually is reviewed what's currently happening across the area and trying to actually highlight best practice, because then if that can be relayed back through discussion here and then also through the LPT and back to the GP services, that genuinely is adding value to discussion and processes involved. Janet.
Yeah, it's just really to add to that, and I declare I am a registered patient of Oakham Medical Practice, but they have actually introduced a callback system now. So if you phone at 8 o'clock in the morning, you press a button and they will call you back. However, we have had a meeting with Oakham Medical Practice staff and the PPG, because we did quite an intensive report, survey and report with over 1,000 responses into a survey in last autumn. And the practice actually said that since they've had the callback system in, although the patients absolutely love it, the amount of calls that they've had has increased substantially, such that they're quite overwhelmed. So need to be careful that, as a patient, I think it's wonderful. As sort of looking at it from the practice point of view, I can see that it's putting extra load in on them as well.
So I suspect maybe we just look at the best practice where there is that balance that works. So if Healthwatch are happy to look at that, we'll take that as a future paper for this committee, and that will be really beneficial for us, I think, to be able to discuss the points that Rachel has made about where this has been done well, and also picking up Jeff's point, which is, how can we stop slightly more enthusiastic GP practices and some of their techniques?
I can't make that decision on my own. It has to go back to our board and to the manager.
Except this is a formal request, and then deal with it through your turns. That's brilliant. Rachel, thank you very much for that. And apologies to Victoria and Justin, but actually you can sense, this is all part of the joined up system, which is where it works and where you can find ways of making it work. It's brilliant. Everyone benefits, and it's just trying to the whole time actually find something that actually just makes the system that little bit more easy to use and responsive. Now, sorry, going back to questions in that case. So Betty, you were next. Then we've got Ross. Then we've got Ramsey for the final question. Okay.
I personally recently have used the online referral system, and it's very good. It's very, very useful. But I think what needs to happen now is to be more people to be aware that system's there, and also to have the confidence in using the system. So what can be done to ensure that more people know the system's actually out there for them to use? And what can be done also to help them to use it? It is quite user friendly actually, but it would be useful to make it more widespread.
So we've got an ongoing, not campaign, but ongoing communications role that we're doing. We've recently engaged a couple of weeks ago with another wide consultation with young people, just again to push out this information and make them aware of it. They had some pop-up shops in the High Cross and in the Haymarket to catch footfall, and at Beaumont Leys. So it's an ongoing thing really, because I think what we found is when we do it once, people miss it or they hear it and then they forget about it. So this is kind of an ongoing messaging, but also using social media, because a lot of younger people who we're really targeting, that's their primary source of information, isn't it? Rightly or wrongly. So we use our comms a lot in terms of just getting key information out on Instagram and Twitter and the like. So, but yes, you're right, Betty, we just need to keep doing at it and keep plugging at it, and word of mouth. I mean, things like this really help, because actually you'll go away and you'll have heard something today that you'll tell someone else, and they may then look online and see what's available, and that helps someone else, you know. So we just keep rolling it really. Thank you.
Right, it's Ross next.
So my question's a two-parter. My first one is about the sort of exponential increase in referrals within the service. And I look at the report, it says a 67% increase year on year for referrals in. And you said that it's a national trend as well. What are the specific reasons for this? I think you said you were looking into it right now, but there must have been national studies done, just the sort of general themes of why this is happening.
And I think there's lots of layers, and I think over time we're expecting to hear more and more as why this is happening. What we do know is COVID's had a significant impact on our young people, undoubtedly. So we know that a number of young people haven't returned back to school. We've definitely seen, and I've noticed myself as a clinician of CAMHS for 30 years, an increase in complexity as well. So we're seeing children that perhaps haven't been seen by any other organisations, and they end up in a crisis situation with us. So I think social media, for all that we see the positive, it also has a detrimental effect on our children's mental health as well. So I think there's multiple layers to it, as you know, but we've definitely seen the impact of COVID on our young people and the challenges they now face in reintegrating back into school and to society, the breakdown of friendships. You know, families have been fatigued by COVID and parenting has been challenged. So I think, yeah, there's multiple layers, and I think over the years we'll hear more and more about those impacts. So yeah.
The national work on ADHD, the Task and Finish group are looking at our prevalence rates of diagnosis compared to Europe and compared to America. So the UK is lower than America, but higher than Europe, and they don't really understand why that is. So again, there's a national research happening at the moment. We're not sure exactly the timeline for that, so I'm presuming it'll be towards the back end of the year before they come out with some valid reasons if they're able to, but there has certainly been that huge lurch in ADHD.
Perfect, thank you. And that sort of feeds into the second part of my question. I think we all agree that we want the service to be there for people that really need it, and they should get it in a timely manner and in the right way. I don't mean this to sound critical, you know, it's a genuine question, but I'm concerned, are we getting the sort of right theming and messages out there? I want to give you an example. So like I say earlier, I work as a dentist and had a patient come into the practice the other day with their family, and she was 8 years old and she had a little badge on her. And I said, oh, are you school prefect? And she said, oh no, I'm a mental health ambassador. And you know, I've been thinking about it lately, and I thought, is 8-year-olds, is that appropriate for someone to have that sort of messaging around them? You mentioned that you think COVID has contributed to this, which absolutely I'm sure it will have had, and I'm sure it will be probably the main thing that contributed to it. So this seems like a novel issue. So if it's a novel issue, you know, are we getting the messaging right? You know, this is a challenge that we've not had before. And so do we need to stop and think? Like I say, I know that might sound harsh. I'm genuinely curious to know, and if I'm wrong, tell me. You know, I'm genuinely curious to know if my thinking's incorrect on that.
Did you ask her what it meant to be a mental health ambassador?
It's a very good question. I didn't. The mum sort of rolled her eyes. I thought we'll get on with the checkup. I was expecting her to say I'm a student ambassador or something like that, or I'm a school prefect, or I'm something or other. But it just surprised me at such a young age, when children are so impressionable. Is that the right level to be talking about these sorts of difficult issues?
And I think it probably reflects that we now see much younger children being referred to specialist CAMHS services, which is very sad in itself. So our biggest cohort of young people were our children of teenage years for a very long time. So we were kind of trained predominantly to work with children between 12 and 18. We now have 6-year-olds being referred into our service with complex challenges and difficulties and requiring a core mental health assessment. So that may be part of it. Yeah.
So a lot of the ambassador roles aren't quite as heavy as it might sound. The title probably gives a misleading. Maybe a wellbeing ambassador would have been a better title to give it. This is about trying to encourage people, young people, to talk about how they feel, not to bottle things up, not to hold things in. A lot of the self-harm that we see is where people have internalised things that maybe they should have talked about, and that leads to behaviours that are actually quite destructive rather than constructive. So the more we can do to get children and young people to talk about what's going on for them, the better we're more likely to be able to then understand it and do something about it. The more we're encouraging them to talk to their parents, the more important it is that parents hear it and can do something about it. The worst thing we can do is bottle things up and hold emotions in and constrain that. So a lot of the roles, the mental health support in schools, that's all about talking. That's all about communicating with each other, treating people with kindness, but also being able to say, actually, I'm not feeling quite right about something, let's talk about it, rather than just holding on to it and then something worse coming of it. So but that helps.
And again, I'm just curious, so those that get referred into the system for an ADHD assessment, what percentage would be diagnosed with ADHD? Just roughly.
About 60%.
Mm-hmm. And I presume there's other support though for those that aren't properly diagnosed. So, you know, if you, like you say, tried other services and this may help you. Okay.
Thank you. Ramsey, last question.
Two questions, if I may. I was wondering if you would like to say a little bit more about the supporting communities and where access to mental health support offers are not being addressed, because I recognise that we have got diverse communities, particularly so in Leicester City.
Good point. So a lot of the work that we're doing with the voluntary and community sector is precisely for that reason. It's about destigmatising mental health, about actually helping them to communicate and use language that's appropriate, but also for it to be seen for what it is and not for something that it isn't. So we've got over 100 organisations funded to provide mental health support to young people and adults across LLR. A lot of those communities, community organisations, come from the communities that they serve and are then best placed to be able to communicate back with their groups. This was seen really well last year when sadly we had 2 young people took their own lives in Leicester at the same community college, and the community organisations that we got in that area mobilised within 24 hours to provide support to the families, to the affected young people, to the wider community. But because it was from within the communities that those young people were from, it had a much bigger impact than maybe someone coming in from outside. So we did debate whether or not we should get one of our other organisations to go and support, but actually being able to say to a community organisation, can you help? And then being able to say, absolutely, we can do this, was far more impacting and actually reduce some of the perceived stigma, negative stigma that was associated with a young person taking their life. So it's really important for us that we have a sustainable model with our voluntary and community sector that actually builds on the assets that we've got. I mean, we call them community assets, but they really are. We've got 25 mental health neighbourhood cafes across Leicester, Leicestershire and Rutland. They're all run by the voluntary and community sector because they're the best place to do it, because they understand their local communities far better than we can going in. So that's really where we see our model growing, and that's what we're offering. Just on the funding side of things, we also make sure that those small organisations that can only cope with a grant have a grant, those that can cope with a contract have a contract. So we have a really good varied model that's tailored around the needs of the organisation, rather than us saying that you have to be of a certain size or bring in a certain amount of money. And what that's done is it's grown a number of organisations coming forward saying that they would like to do something with this particular community in that particular area. So it's a real strength that we've got that in LLR, and one that we should be really proud of.
Thank you. My second question deals with the last 2 points, because I believe they're actually interrelated. And you talk about the challenges of recruitment and retention and development of staff. and part of that is about the environment within which they work. And you also make the point about availability and effective use of the estate space. And I have got an obsession or a theme from these papers, this particular meeting about. So could you say a little bit more about what you're doing to manage the estate and make best use of it? Because I see this very much in terms of capacity planning, and if we can improve that, it improves process flow, it improves the motivation of people because the working environment is less stressful. And I've been concerned that I've come to 2 meetings now and I see that this being flagged up and I don't understand why. Thank you.
So it's flagged partly because it's very costly. As you'll know, I mean, this building alone is now being utilised by more organisations than it was, say, 5 years ago. And that's because actually the overheads of running a building are extensive. And when you look at the number of organisations that we've got that are using estate for one purpose only and has time when it's not utilised at all, it's not cost effective for us, and when every penny counts. So if you look at, for example, I spoke about the neighbourhood cafes, they don't have a cafe in their own right, they go and they run their cafe in someone else's building. So if I use Littleworth as an example, that's my local area, they run the neighbourhood cafe in the leisure centre, and they have a number of hours that they're in there for, and then that's used for other things as well. So that's what we mean about utilising our estate in a better way. This isn't about having a special building for a special purpose. It's actually you've got a building and how many different organisations or how many different services can we run from that. The banks are doing it, aren't they? Again, Littleworth, I know, has now got the one bank that has multiple banks in it. It's the same premise. So what we're trying to do is say we'll only have the estate that we need, but what we've got, we need to really be able to utilise to best effect. And is it actually in a central location that people can get to? And have they got, it's almost the one-stop shop approach, really. But from a mental health and wellbeing perspective, that's key for us. So, but that's why you'll keep seeing it, because it's a hot topic.
I just would like to say also we are connecting with the family hubs work as well. So I've definitely got links within each of the areas. So we are kind of listening all the time to possible estates that are coming up in local areas. You know, we hear more and more about families wanting to be seen in their neighbourhood, place-based offer. So it kind of really fits with that family neighbourhood hub model. So yeah, so we are really connected with that to try and utilise as much space estates as we can.
Ramsey, is this question 3?
No, it's not question 3. It's just to make a point. I think the issue of estates management is extremely important, and I think it's been highlighted by Jeff in regard to A&E and how these facilities are actually used. And I think this is a subject that is worthy of a little bit more delving into in terms of how we actually capacity plan within the context of the built estate that we actually have, because we tend to view it in discrete segments, if you will, whereas there's a certain common theme I think that is worthy of investigation, shall we say.
Okay, thank you. We'll give some consideration to that, because I mean there is obviously a huge amount of complexity, because quite often, as Victoria sort of mentioned and Justin mentioned, you know, what's deemed to be estates or associated with it is not necessarily it's sort of rented space. Likewise, you know, there are, you know, this building alone contains huge chunks of the NHS and other organisations where they are subletting to make it more efficient to be in one place, and I suspect that then you get down to GP practice where they are, you know, owned probably entirely by the GPs who are the practice managers, etc., etc. So the ownership and the leaseholder of the estates that we are looking at, I suspect, are pretty varied. We'll have a look at it. Ewan can put his thinking cap on and see whether there's actually a question that and the right organisational structure that we can actually have a look at. Janet, on this one.
Yeah. I think that was a really valid point, Ramsey. I would ask that if you're actually looking at it, would you bear in mind that rurality, as Rutland is, very rural area, but so is lots of Leicestershire, poses real problems for actually getting to a central location like Leicester, not just because we don't have a proper, a very good public transport infrastructure, but the sheer cost of it. So yes, we've been pushing and we've been asking for a long while for everything to be, more things to be coming out to the local, so people can actually access the services. So
it's that balance between what's affordable and what's practical, I think, and I think that may actually come out of the discussion, which is actually, continuous change, service provision, how we actually do that, but at the same time, how can we actually still make sure that organisations are porous, that people can still access what's required in the way that actually suits them, and the point, about making sure that the barriers aren't there, that people then get diverted across to absolutely the wrong part of the system, is also important. But as I said, we'll have a chat and see whether we can't actually come up with something that actually is a sensible way of actually looking at this across various organisations, because you're right, it comes up, everyone has an estates issue, every organisation, whether it's Rutland Council, whether it's Leicestershire County Council, whether it's Leicester City Council, plus also all of the NHS and the LPT and all the other ICB type elements within that. But getting the best efficiency and access is going to be quite interesting. Okay, well, look, thank you very much, Justin.
Sorry, can I just make one more point? On the 2nd of April, NHS 111 option 2 goes live, and that's an all age. So if you're having an issue with mental health, at the moment we have a crisis line. As of the 2nd of April, you ring NHS 111 and you press option 2, and that then brings you straight through to our local central access point team. We've upskilled this team to deal with support both children and adults, but it's just to make that point on the back of the letter that's talking about 2 days triage. The crisis line will be available to anyone 24 hours a day, 7 days a week.
That is an exceptionally useful bit of information to know. Yeah, I'll ask you, and if you're happy to put that through to the respective organisations and maybe liaise specifically as well. We'll try and get that flag across. I must admit, that's information that's completely passed me by, and I pride myself on reading everything to do with the NHS. So thank you very much for that. That's really, really useful. Look, Victoria, Justin, again, thank you very much. It's been a really, really interesting session. Has raised all sorts of fascinating points that I didn't expect to get out of this session. So likewise, I think probably for everyone else as well. So really, really good to talk to both of you. And thank you very much for answering our questions and being here to spend some time with us. So thank you very much indeed. That's very, very kind of you. Thank you. Okay, we now move on to item 9, which is the Leicester, Leicestershire and Rutland Joint Health Scrutiny Committee Terms of Reference. Now, Ewan is here as our Senior Democratic Officer to answer any questions. Can I just ask everyone? Everyone understands that this is a procedure that is being done up and down the country, etc. You may have endless questions. I do remind you, it's almost 4 o'clock. It's past 4 o'clock. Does anyone have any pressing questions, or does everyone understand what this is about? Nods of head. Ewan, are you sure you want to say anything?
2 points.
2 points. Go for it.
Just a couple of things that I didn't mention in the report. One is that members of the public can also make fill in the form to the Secretary of State and request that the Secretary of State looks at it. So that could be quite an interesting thing, depending on how many members of the public want to do it. So we're going to just have to work out how that's going to work. And the other thing, just to mention, the guidance says that we should create a memorandum of understanding across the different organisations, the ICB, the different authorities, regarding some of the more detailed arrangements. So I'm going to be working on that over the next few months and may bring that back to the committee. And we may cover the sort of the members of the public issue in that memorandum of understanding. So, but just for today, we're just asking you to change the wording in the terms of reference.
Okay, thank you very much. I'm going to make the proposal that we actually accept this. Jeff, are you happy to second that?
Yeah, certainly will.
Can I see everyone? This is the only time Scrutiny ever gets to vote, so enjoy doing it. Brenda, you're not voting for this. Oh, come on, 100%. Look, there we go. Right, fantastic. We're all in agreement. Ewan, thank you very much. You can say the only vote that Scrutiny's ever taken was 100% in agreement, and it was all thanks to you. Okay, look, thank you very much. Item 10, any other items, Chairman decided to urgent. There are no items, so I declare the meeting closed. Thank you very much for your attendance.